Good morning. Welcome to the start of this session, today's session. Thank you, Dr. Pandap sir, for giving me the opportunity to be at this instruction course. So I will be discussing indications and preoperative considerations of radiculectomy. Now, radiculectomy is still the gold standard surgical option for lowering intraocular pressure. Now, radiculectomy is required when medications fail to achieve the target pressure with progressive damage, and it can be performed in most of the primary as well as secondary glaucomas, but the prerequisite is intact, non-scarred conjunctiva. History of any previous ocular surgery is really a challenge. Now, any glaucoma surgery at best can hope to maintain and not improve the vision. If surgery is appropriate for a patient, it may give good long-term intraocular pressure control and visual field preservation. But the main complication is failure due to scarring. Of course, there are others like hypotony, infection, hemorrhage. Now, decision to operate should be appropriate, and follow-up is very vital to get the successful surgery and to take any remedial measures for any identified deficiency. Now, radiculectomy, history of any previous surgery may be extracapsular cataract extraction, small incision cataract surgery, scleral buckling or penetrating keratoplasty. So history is very important to know the preoperative status of the eye. When surgical risks are outweighed by the potential benefits, as when high pressure put the patient at significant risk despite maximum treatment, or there is progressive glaucoma damage resulting in significant visual disability. Now, any significant variant for using medications like affordability factor or poor compliance or any ocular or systemic side effects. Surgery is also considered if there is any inconvenience in putting the multiple drops, or there is physical impairment or any psychosocial issue. Other is rate of progression is rapid in terms of deteriorating disc and visual fields that will result in symptomatic visual disability. Of course, there is prior unsuccessful laser as in angle-closure glaucoma. Now, it can be done in any types and stage of glaucoma. The ideal treatment is, of course, anything other than surgery like conservative or lasers. Now, challenge is when to decide when to go for surgery and prefer surgery over the other treatment modalities. We have to outweigh the potential risks and benefits of the current treatment modality. It can be performed in primary open-angle glaucoma, secondary open-angle glaucoma, pigment dispersion. Then primary angle closure glaucoma not responsive to laser iridotomy or iridoplasty. Secondary angle closure glaucoma. Then other indications could be pseudoexfoliation glaucoma. Then primary congenital glaucoma, where surgery is the primary mode of treatment. Then any traumatic glaucoma like angular recession glaucoma. And some of the relative indications are neovascular glaucoma, where prior to surgery you can use presently elastin or anything to improve the success rate. Sometimes in uveitic glaucoma also with use of a gentle you can do radiculectomy. Now, any previous problem with fellow eyes such as failed surgery or problematic response to filtration surgery, if you go for surgery in other eye, you have to keep all these things in mind. Then, very critical for success is careful history taking, evaluation of any systemic disorder, any focus of infection you have to look for ocular adnexa, conjunctiva, evaluate corneal endothelium, anterior chamber, angle and lens status. Structural and functional status of disc is also evaluated. In preoperative considerations, rapid intraocular pressure reduction is not desired for risk of decompression, retinopathy and suprachoroidal hemorrhage. And intraocular pressure should be well controlled before entering the eye. Medically, our use of hypotensive agents or hyperosmotic agents like mannitol. Look, preoperative preparation should be optimal. Look for any focus of infection. No infective risk factor should be present like TTACs and topion or dactylocystitis or any other focus of infection. In case there is any conjunctival inflammation or any other inflammation, use the appropriate medicine in the form of steroids or antibiotics. Topical or conjunctival inflammation and systemic intraocular inflammation. But still, bar for any steroid response. Ask for any use of drugs like myotic prostaglandins which induce inflammation, so they should be stopped prior to surgery. Age of the patient is very important to decide the surgery. If the patient is very old, you may only limited pressure loading is required. You may opt for other options like conservative or pelvic plasty. Look for focus of infection in lacrimal sac, stye or entropion. Staphylococcus, peripheral anterior sanity. Any developmental anomalies like axial field anomaly or aniridia, you may require use of viscoelastic to deepen the anterior chamber. If there is any significant associated cataract, we may go for a combined procedure. Then, in case of uveitis or neovascular glaucoma, the eye should be quiet at least for 3 months prior to undertaking patient for surgery. And neovascular glaucoma, prior use of Avastin and photocoagulation are mandatory to get the good results. At the table, use a drop of iodine 5% in the conjunctival sac. Move the eyelashes out of operating field and the use of sticky trap. Counseling of the patient is very important. Discuss with the patients about the possibility of blood using post-operatively for 2 to 3 weeks. And also counsel the patient that there will not be any improvement in vision. And in conclusion, it is still the widely performed surgery. Claviculectomy is first surgical option for majority of glaucoma. Pre-operative evaluation is very critical for the success of the surgery. And use of the injectives like MMC, 5FQ, Avastin, and these which they have improved the success. Thank you very much.